You know, there's a tumor out there with a name that sounds like it's straight out of a monster movie, the giant cell tumor. But honestly, the scariest thing about it isn't the name, it's the puzzle it presents to doctors. So let's jump right in.
I want you to think about this for a second. What if a tumor that's technically labeled benign, non-cancerous, didn't act benign at all? What if it had all the local aggression of a malignant one? Well, that's the exact mystery we're going to unravel today.
And here's how we're going to do it. First, we'll look at its contradictory nature, this whole aggressive imposter thing. Then, we'll figure out who's most at risk. We'll look at the signs and symptoms, uncover the one huge clue that cracks the case, and finally, see how surgeons actually fight this thing.
All right, so let's get right to the heart of it, to this paradox. How can something be labeled harmless and yet be so destructive at the exact same time?
So what in the world is a giant cell tumor, or GCT? Well, the technical term is osteolytic, which is just a fancy way of saying bone-destroying. And right there, in that one sentence, you see the contradiction. It's classified as benign, but it acts like a wolf in sheep's clothing, just relentlessly attacking the bone where it grows. And the line gets even blurrier. About 5% of these tumors are straight-up malignant right from the get-go. And for the ones that start out benign, well, another 5% can actually become malignant down the road. So that benign label, it doesn't mean you're totally in the clear.
Okay, and this is where that imposter label really fits. Even when it's officially benign, in up to 5% of cases it can metastasize, that means spread, all the way to the lungs. Now that is something a benign tumor is just not supposed to do, period.
So you have to ask, where does all this aggression come from? Well, surprise, the name giant cell tumor is actually pretty misleading. The giant cells? They're just kind of along for the ride. The real engine of all this destruction are these smaller spindle cells. You can think of them as these tiny, hyperactive ringleaders causing all the chaos, while the big, giant cells are really just part of the crowd.
Okay, so we know what this thing is, but who is most at risk from this aggressive imposter? Let's build a profile.
Well, this tumor definitely has a type. The peak incidence when it shows up most often is in young to middle-aged adults. We're talking typically between the ages of 20 and 40.
And there's also a slight gender difference here. It turns out females are affected a bit more commonly than males.
These tumors also have their favorite places to hang out in the body. By far, the most common spot is around the knee, so in the bottom of the femur or the top of the tibia. But they can also pop up in your wrist, your shoulder, and even in the spine.
All right, so we know who gets it and where it likes to show up, but how do you know you have one? What are the physical clues it leaves behind?
Usually, the first warning signs are what you might expect: a deep, nagging, persistent pain and some noticeable swelling right where the tumor is. It's the kind of ache that just doesn't go away with rest, the kind that eventually makes you say, okay, I gotta call the doctor. But here's a much weirder, much more specific clue a doctor might find. During an exam, when they press on the area, they can sometimes feel a sensation like they're crackling an eggshell. And why's that? It's because the tumor has literally eaten away at the bone from the inside out, leaving that outer wall incredibly thin and fragile.
Now that eggshell clue is a huge hint, but the definitive evidence, the absolute smoking gun, is found on an X-ray.
So, when a radiologist puts that X-ray up, they're looking for a very specific pattern. They see a lesion that's destroying bone, they see that the outer wall of the bone is thin and bulging out, and, really importantly, they see that the body isn't putting up much of a fight. There's very little of that defensive bone hardening you might see with other issues. And when you put all those features together, you get the smoking gun, the classic soap bubble appearance. As the tumor hollows out the bone, it leaves behind these thin little ridges, and the whole thing creates a pattern that looks just like a cluster of soap bubbles. When a doctor sees that image, well, the case is pretty much closed. They know they're dealing with a giant cell tumor.
So, the diagnosis is confirmed. Now what? How do you fight an imposter that's this aggressive? Well, you have to be just as aggressive right back at it. And the approach is really non-negotiable. The treatment for a giant cell tumor is always surgical. This is not a watch-and-wait situation. You have to go in and get it out. Now, the type of surgery all comes down to one critical factor. Has the tumor broken through the outer wall of the bone? Is that cortex still intact, or has it been breached? The answer to that one question changes everything. If that bone wall is still holding strong, surgeons can perform what's called curettage. It's basically a very, very thorough scraping to clean out every last bit of tumor tissue. Then, of course, they have to fill that big empty space, usually with a bone graft, a special kind of bone cement, or sometimes a combination of both. They call the sandwich technique.
But if the tumor has broken through the bone, the surgery gets a whole lot more serious. We're not talking about scraping anymore. We're talking about excision, removing that whole section of bone. This can mean really complex reconstruction, sometimes even needing a full prosthetic replacement, especially for tumors around the knee. The major exception here is the spine. Because it's so complex, radiation is often the go-to treatment there instead of surgery.